Hello, everyone, and welcome to another one of our live doctor Q&As. We are so glad you're here and so glad for those of you that are jumping in. Welcome. We're going to have another great session tonight. If you've never been to a Winona live Q&A before, welcome. We're so glad you're here. These are a really great experience where we get to talk to some of our amazing Winona doctors. And I'll have them introduce themselves in just a moment. But I just want to go ahead and say you'll find a little chat button down at the bottom. And I already see Hadassah's in there. So if you see the chat in there, you can start chatting away. But we like to say if you have any questions, it usually gets a little crazy. We get a lot of questions. So go ahead and throw your questions into the chat now. And we'll get to them as soon as possible. I see Suzanne's in there now. She says, hi, Suzanne. We're glad you're here. But yeah, go ahead and throw your questions in the chat there, and then we'll get to them. We'll try to get to as many as we can during this hour. But I'm going to go ahead and let our doctors introduce themselves, and then they're going to talk a little bit about October and what that means for this month, and then we'll get into your questions. So, Dr. Green, if you want to jump right off for us, and then we'll jump into things.
Great. So, hi, my name is Mike Green. I'm an OBGYN. I actually did a family practice residency first and fell in love with women's healthcare and decided to do a full OBGYN residency after that, which is what I spent most of my career doing. For the past 5 years, this has been my passion, maybe a little more than 5 years now. We launched about 4.5 years ago. There was a lot of planning to get started. And Winona's just been this great platform to be able to reach women and get them hormone replacement therapy that they need, where they otherwise may not be able to get it. Because unfortunately, there's a lot of misinformation. There's a lot of doctors that haven't been educated. And people go into their doctor's office, sometimes get turned away when they show that. So we're super happy to be able to bring Winona to you and take care of that. So I'm the Chief Medical Officer. I'll be super excited to answer your questions. That's one of the things. That's one of our founding principles. One of my passions, education, and that's here to unite. It's to answer your questions and what you stay informed. So I'll turn it over to Dr. Kat.
All right. Hi, everyone. I'm Dr. Kat Brown. I'm also a board-certified OBGYN, and I'm our medical director at Winona. And you might see me all over our social pages and stuff like that. I'm doing a lot of educational videos as well. But I also fell in love with women's health, and this has become a very special project within my career because I'm also one of you. I'm also a patient who is currently in the throes of perimenopause, dealing with symptoms. So I know exactly what you're going through. And I think it's so very important that women help to educate one another, that we seek out the knowledge that we need to try to do the best that we can, so that we can empower ourselves to get better care and live a better life. No reason to suffer. And just make sure that we can do better for our other generations after us too, so that we don't have to suffer in silence like our mothers or grandmothers maybe did. So that's why we're here, to answer your questions and to just make sure that you feel more comfortable and come out of this webinar tonight learning something from us, hopefully. And we also just wanted to talk about every month there's like a special month, a special, significance. And October is a big one for women's health because it's Breast Cancer Awareness Month. So if you're not aware of that, you might see stuff all over. There's breast cancer awareness, and breast cancer research has gotten a lot of, airtime and press. But it's really important for you as a woman to make sure that you take the time to get your screening mammogram, to get a breast exam, and to really have that self-surveillance to know, is there something different? And make sure that you're aware of what's going on, and keeping up with that preventative health care that you need to make sure that you stay healthy. And so it's something that's so preventable, and if breast cancer is caught early, if a mass is caught early, it's highly treatable, but you don't want to ignore it. So it's something really important to consider. And October is a good time, since it's Breast Cancer Awareness Month, to put that on your calendar. Make it boob month for you. Make sure that you're getting your mammogram if you haven't, and that you're paying attention to the breast health as well. So I don't know if you want to add to that, Mike.
I remember when I got my first car, my grandfather said, "Don't take care of your car won't take care of you." And it's the truth. True with your body. I tell my patients that if you don't take care of your body won't take care of you. I'm 61. I can tell you all the stupid things I did when I was younger are coming back to bite me. So you take care of your body, and that preventive maintenance is super important. So just like you get your oil changed with your car, you get your mammogram. I am a big advocate of getting it every year, and there's some controversy about that. But really, that strategy is the best strategy to decrease the incidence of breast cancer. So that's my advice. My wife gets hers every year, and coincidentally, I was scared. It's probably starting. Sometimes the bill for the mammogram hits the same time as the bill for my oil change. Oil change costs more. All right, why don't we get to some questions?
All right. Yeah, we have a couple in here, so we can jump right on in. So our first question is from Christine. And Christine says, I'm considering beginning a hormone replacement therapy. She says, I'm 53 years old, but she says, I'm somewhat apprehensive about starting due to potential side effects of bleeding. Can you explain this a little bit more and what I might expect Yeah.
Yeah. So for some women, as they're starting HRT, it all depends on when you're actually starting hormone replacement. So if you're someone who's still having cycles, it's potential that you might notice some mild changes in your period when you start hormone therapy. If you're already postmenopausal, meaning that if you've gone a full 12 months without a period and you are not getting a period anymore, it is possible to experience some spotting occasionally when you're first starting hormone therapy. Not every patient will go through this. It's something that, is common, but it's not something that you could count on and depend on. I've had plenty of patients that start, HRT and do fine and don't have any of the erratic bleeding or spotting. So it's something that you'll, be aware of. It is something that we talk about with patients, but just because, you read that somewhere doesn't mean it's going to happen to you. Every patient is unique. Everybody's situation is unique. So that's something that if you're suffering with symptoms, you always have to weigh the risks and benefits of any treatment. And if you're dealing with significant symptoms and they're affecting your life, think about where that falls in relation to the potential risk of having a spotting event or something like that. So only you can make that decision as the patient. You know your body. And if you have questions or you're not sure, if you're a good candidate, you can certainly go through the onboarding process and we can talk to you about it more after you've gone through and, done the onboarding with us. But we can certainly answer your questions too.
Kind of add on to that, and yet, generally, if people do absent abnormal bleeding, it's really in the first couple of months, and then it goes away after that. And if it doesn't go away, there's probably something behind it on this picture. So is this a temporary thing if it happens? But most people it doesn't. And the other thing is that there's kind of a couple of ways to do HRT. We use a DHEA exposure. Use this in there every day. There are people that cycle their progesterone, and when you do that, it will force a period. So if you're postmenopausal, have that period, so put you on cycling progesterone, it can make you have a period again, which it's kind of, most people say it's like the one benefit of menopause is you have periods. But the way we prescribe it really should do that. So for most people, bleeding is none or minimal and short-lived when it does happen. So if you're hanging there, even if it does happen, choke it all.
And it looks like our next question tonight is from Michelle. And Michelle says, hi, I have a question about the Tretinoin cream. She says, it seems like it's very harsh on my skin and now I can't use it. I'm wondering if there are other ingredients to soften it up or kind of what might be going on there.
Yeah. So when you first start a Tretinoin product, the way that this product works is by helping the skin renew. It's actually causing, the skin to kind of slough off, and that's how it does the anti-aging. It's making that younger, newer skin that's underneath emerge. So in the first few months of starting, sometimes for weeks for some women, you'll notice it might make you feel over dry. It's very important. We talk about kind of doing a layering with like a barrier cream. So if you're somebody who's really prone to dryness or you've had sensitive skin, you do a very, very thin layer. I think that's the other misconception too. A lot of patients start applying the face cream and they feel like, well, if it's anti-aging, let me lather it on. I really want to get the anti-aging effect. But you want to do a very, very small amount, very, very thin amount. And usually we tell you to do the targeted areas first. Um, and then after that, once the product has dried on your skin, you can do a nice, gentle barrier cream to really help kind of lock in moisture as that medication is in. And normally you start out using it, a couple times a week. And then when your skin's tolerating that, you add another application in. You don't want to start off right away putting this on every single night because you will feel like a lizard and your skin will start to peel and get very dry. So it's a gradual thing. You have to kind of get your body to accommodate to the changes. But once you start to see the benefits and once you really start to notice the texture changes in your skin, which are really beneficial, you will notice that drying effect gets less and less over time as well. And then patients are able to use it more frequently. So it's initial, getting over those side effects of the drying and the irritation. And so it's really important that you get a good moisturizer that also doesn't have any irritating ingredients. The problem is for a lot of moisturizers, they have other things in them that with the tretinoin could be irritating to your skin too.
Yeah, less is definitely more, especially if you're having problems. I would use a third of what you're using and just start with once a week. Just gradually. Thanks.
Absolutely. And we have another question from Michelle. And Michelle says, I've been hearing some others saying not to get mammograms due to some kind of side effect. Could you talk a little bit about this?
Let me grab that one. Okay. So there have been studies on the radiation effects of mammograms. It's really a teeny amount of radiation, and the amount of radiation exposure to a yearly mammogram is insignificant, especially compared to the benefits of fighting cancer. So that's the thing that people worry about is, gee, irradiating my breast is not going to give me cancer. And the answer is no, that's been studied. The controversy about how often to do mammograms is about money. It's not about health. And so, we used to do mammograms starting at 40 and do every year. And somebody did the math and they said, what does it cost to do all these mammograms and the follow-ups? And what does it cost to just let people get breast cancer and maybe breast cancer treatment? That was literally the equation that was done. And so when they balanced it out, they found that if you waited until 50 and then did them every year, that's where the break-even point was from a monetary point. I think that's a terrible way to do healthcare, right? Because, that's what it costs, but talking about people's lives. And so there was actually a negotiation. American Cancer Society went nuts over this. And they kind of negotiated down to this 45 where they are now. But if you look at, your question isn't, how do I save money? Your question is, how do I save lives? The answer is structure mammograms at 40 indeed. And to me, that's the right way to do medicine. I don't know how you feel about it, but for me, as a doctor, when I'm working with a patient, my job is not to protect the greater being of society. It's to protect that patient's health. What's in the best interest of that individual patient. And that's to start at 40 here. So that's where this controversy comes. People don't like to talk about it because talking about healthcare and money is kind of a scary thing. But that's when you see those kind of recommendations. It's really what's the most cost effective, and you're trying to live on healthcare like you're about a deli. That's not the right way to do it, everybody.
Right.
Absolutely. And our next question is from Karen. And Karen is wondering, she says, is the HRT provided through Winona the same level or medical grade level as what one might get from an in-person OBGYN?
Yes, I mean, the medications are very similar. The main difference is that we're only using bioidentical hormones at Winona. So, we're still using estrogen that is pharmaceutical strength. This is a prescription that we're providing to you. This is not an over-the-counter medication that you could buy like on Amazon or anything like that. So in that way, it's very similar to what you could get a prescription from your in-person physician. But the difference is that when you get prescriptions from your in-person physician, there's a lot of different varieties of medication that you can get in the form of HRT. And some of those are synthetic estrogens. Some of those, are not the same as what your body creates naturally on its own. So that's the main difference. And also, we truly exist for those patients that don't have access to a doctor in person who's willing to prescribe. Or maybe you're someone who lives very far, and maybe in a more remote area, and it's a real hassle to drive 2 hours to get to the doctor and another hour to get to a pharmacy and go back and pick it up. And the benefit of getting medications from us, too, is that it's mailed directly to your home, these prescriptions. So you have that convenience factor as well. And you also have access to our doctors 24/7 in our portal to message us with questions anytime that you have an issue. Whereas when you're getting a prescription from your doctor in person, you might have to wait 3 months until your follow-up visit to be able to ask them questions or have concerns, addressed. So that's the main difference.
Yeah, I always also say that the pills and the patches are the same as what your doctor could prescribe, and we could get at your CVS or the idea. Well, yesterday it's gone, but wherever you go. The cream is really kind of where we shine. And so I would say not only are they as good, but it's better. So we are the biggest provider of compounded HRT in the product range country. And compounding is a bit of an art. And so this is what we do. We do it extremely well. And I've had several patients over the years that have decided to go with their local doc and their local compounding pharmacy. And a few months later, they come back and they say, it's just not the same quality as what you're providing. Can I come back a what? So if you're getting the pills or the patches, they're basically the same as what your doctor prescribed, if they chose to prescribe that choice. But the creams are going to be higher quality than they find anywhere else, just because it's what we do. You do it extremely well.
Absolutely. And our next question is from Marilyn. Marilyn says, I have a question about dose, which is I read recently that the traditional convention on doses, starting with the lowest dose, is not enough and way too low. What is your take on this?
Well, we tend to, as physicians in general, not want to overprescribe or start you on a high dose because then you have a higher likelihood of having side effects or having problems. So in general, we tend to be more conservative and start low and then gradually titrate or increase that dose until we get your symptoms under adequate control. So there's no magic number. There's not a magic formula. Every woman is unique, and it really is a bit of trial and error to try to figure out what dose works best for you. But yeah, the old adage of the lowest dose for the shortest amount of time period possible was the guidance that we used to get years ago. When there was a widespread fear about HRT and the risks of HRT. But now we know that staying on HRT long-term, especially when you're doing well with it and it's helping with your symptoms and you don't have other medical issues that make it more complicated, women do very well and actually have really long-lasting great benefits for their health and their vitality staying on hormone therapy. But yeah, starting low and titrating up as we need to is a better way, and it's a safer way to get you the relief that you need safely without bombarding you with side effects. That's why we tend to do that.
And it looks like our next question is from Melissa. And Melissa says, and you might need to help me with this one. She says, I have a higher hematocrit?
Hematocrit.
What? Thank you. And everyone who's on the call, you see, this is why we have doctors here on the call. You're able to help with that. But she says, I have a higher level and donating blood to reduce my levels. She says, is it safe to take DHEA and estrogen?
Do you live at, I'm just curious if you live at altitude. I live at 6,000 feet, and everybody here has a high hematocrit. Some people high enough that we have to do the same thing. Or it's possible you have hysterectomy or something else. So it kind of depends on how high it is and why it's that high. So it's something to ask your when you got here.
Sure.
And if you can upload the blood count, it's called the CBC, that would be very helpful. So you can easily do that in our portal, and then they can look at that and talk to you about, trying to figure out why it's high. If you're living in Colorado at altitude or in Lake Area, that that type of high mammograms will do.
And it looks like our next question is from Jennifer. And Jennifer is wondering, she says, can my DHEA be increased some on the 3rd month? She said, I'm still having hot flashes. So I think a little bit about what the process is for kind of what that looks like.
Yeah. So if right now you are only on the DHEA alone and you're continuing to have symptoms, it might be time to have a conversation with your doctor as to whether or not you should consider adding in hormone therapy like estrogen and progesterone as well. We do have several patients that just want to start with the DHEA, but for significant menopause symptoms, sometimes that may not be enough to really get your symptoms under control. So worth a conversation, and you can feel, empowered asking the question here that you go right onto that portal and you message your doctor and say, hey, I'm still having these symptoms. What can we do about it? And we can talk to you about adding those other things in.
Absolutely. And our next question tonight is from Amy. And Amy says, I had a hysterectomy in my, she said, I had a hysterectomy in my 30s and hit menopause in my early 40s. I'm on estrogen only with HRT with Winona for a few weeks now, she says, in my late 40s. How long can most women stay on estrogen? She says, I think it's already making a positive difference. It has been hard to find care providers even willing to talk about HRT, and I'm so grateful. But her question is, how long can women stay on estrogen?
Well, so with any medication, it's going to be something that, whenever the time comes, to reevaluate. You could stay on the estrogen as long as you feel good on it, and you don't develop any other medical problems that would make the estrogen, more risky for you. So for most patients, they decide to stay on it kind of indefinitely at this point. I'm kind of in that boat personally that, I feel so good on the estrogen. If I ever have a time where I forget to change my patch and I feel it, it reminds me why it does such a good thing for my body. So a lot of patients stay on it. But, when you're having your preventive health visits and when you're doing a physical, every time you go in and get evaluated, as we get older, you really should be taking a look at your medications and determining, what's still worth taking, what can we kind of wean down. We want to avoid something we call polypharmacy, which is when there's so many different medications people take and they can interact with each other. And so it's something that you revisit over time. But if you're feeling good and everything's going well, there's no reason to start planning the stopping of it just yet.
And our next question, and this was tied to the earlier question about the Tretinoin cream. And I think you were talking about maybe getting a moisturizer, but Michelle is wondering, is there a specific type of moisturizer you might recommend for this?
Yeah, I wish we had Jo with us because she's our resident dermatology expert. But yeah, there are several different things. You want to definitely stay away from anything that has alpha hydroxy or anything that has other types of, products in it that are supposed to help, renew the skin, anything that has another tretinoin product in it. So in general, you want to stick with things that are considered to be a non-comedogenic, meaning non-acne causing, non-pore clogging, and a barrier cream. And for some reason, I'm blanking on the brand I use, but I use something that our dermatology expert recommended. If I get on my Target app real quick, I might be able to. But the brand, there's several different brands that are out there, that are really good, that are dermatology recommended, like Cetaphil, or the company I use is La Roche-Posay. They have a lot of good skin products, and they have a really, really good, it's called a double repair face moisturizer. This is a French company, so a lot of the labeling on the bottle is very French, and I don't have a good French accent, but it's like Toleriane double repair face moisturizer. That one's a really good one. But in general, when you go in that aisle, Neutrogena makes good moisturizers. There's a lot of things that are various price points, and so obviously pick something that is going to be affordable for you. And I usually tell patients to kind of go with a smaller size at first. Make sure your skin tolerates it before you buy a jumbo size at Costco or anything like that. But just something that's a simple, repairing or barrier moisturizer for the face that's not going to clog your pores.
Absolutely. And I love that you mentioned Joe. Oh, Dr. Green has something to say. I'll let him get to that. We have a course coming out.
That's pretty good. Medicine cabinet, probably from the same conversation.
Oh, she has the same company in her cabinet. Yeah.
Well, Joe recommended. Joe's our head of patient services, but she's an amazing lady. She's a nurse practitioner, and she worked in a derm for years, and we are just incredibly lucky to have her. So she's very, very helpful for us.
Absolutely, yeah. And with Joe, we'll also be having a skincare course come out from her in the app. It should, if it's not already out, it'll be out in the next couple days. So keep an eye out from that. And so there'll be lots of information in there from her as well. Our next question is from Erica Coleman. And Erica says, what happens, or she says, what about if you get a rash from the medicine? She's been currently on estrogen and DHEA prescribed. What should I do in this case?
So the question would be, like, if you wrote to me on the portal telling me about a rash, I'd want to know, like, where the rash is, how long have you had it? Are you using estrogen cream? And is it in the location that you're applying the cream, or is it something more diffuse? So it's hard to know, what exactly it could be without knowing those details. So feel free to reach out to your doctor and let them know. If it's in the location, like if you're using our topical compounded cream and you're noticing it where you're applying the cream, it might be worthwhile switching to another method. But that's something that you definitely want to talk to us about.
And our next question is from Maxine. Maxine says, I am perimenopausal, but I'm still menstruating. She says, I began HRT cream almost 2 months ago and have not had a cycle. Should I be concerned?
Well, so when you're in perimenopause, depending on how old you are, it can be normal to have some erratic timing to your cycles. That's one of the earliest symptoms that women notice in perimenopause, is that sometimes their period, which used to be like clockwork, is no longer as predictable. And sometimes you can get some changes in relation to starting HRT, but it also could be your body's own internal clock changing things too. So keep an eye on it, and it's something that you can certainly bring up, with your follow-up and just let them know. My other question for you, if I were your doc, is I would ask you if you're having any like PMS symptoms. Like, are you getting any symptoms like you're going to get a cycle and maybe you're just not having a bleed? That you usually would include like breast tenderness. Sometimes our moods might get a little bit more fluctuant the week before we would get a cycle. If there's any symptoms that you typically would get before getting a period in the past, I would want to know if you're having any of those.
What is this? Less bleeding tends not to be so worrisome. Skipping cycles, I don't really get our antenna out if there's something sinister going on. Whereas if you're bleeding all the time, that's obviously something that piques my attention. So that doesn't represent anything dangerous.
And we have a question next from Adriana. And Adriana is wondering, she says, I have my period. Can I still use the cream?
Yes. If you are having symptoms that are bothersome enough to you that you're seeking treatment, it's totally fine to start the treatment before your period ceases. So that's one of the other big misconceptions and why there's a lot of doctors out there that are unwilling to treat women that are younger starting to have symptoms. They really feel like you need to wait until after your period stops. But actually, more and more research is showing us that women who start hormone therapy younger actually have better outcomes long term when they start the hormones at an earlier age rather than waiting until they've completed menopause. So, yeah, it's perfectly fine to start them now.
This is one that drives me nuts because we get patients that say, oh, my doctor says I can't have HRT until after my period stops. And then the next patient will tell me, oh, my doctor said since my period's already stopped, it's too late to start HRT. It's like, oh, you get started. Yeah, the best time to start HRT is when you start having symptoms, regardless of what's going on with your symptoms.
And our next question is from Suzanne. And Suzanne says, I'm just getting started with Winona, and I have been full menopausal since 2015, and I'm only 54 now. She says, I've been dealing with extreme inflammation since then, and I've had many different regimens that have lessened the pain but not reduced the inflammation markers. She says, it's my last hope to use HRT. I've also found out that my testosterone is very high per the Dutch urine test. But I don't think it's turning into estrogen like it's supposed to because my libido is off the chart. I am wondering what I'm going to experience to know that it's working and what setbacks I should watch for.
So you should know that we're not big fans of the Dutch testing. I don't know who would open that whole can of worms.
That we both like
Yeah, you could watch our facial expression. So the Dutch test was something that was invented by a man looking to make some good money who was a biomedical researcher, but not an OBGYN and not a menopause specialist. It's not been validated by the medical community, and it doesn't really give me good information as your doctor to know how to best treat you. It's a lot of information. It's very expensive that patients have to pay out of pocket for. So that's my little diatribe on that. Really, when you're starting the medication and you're starting HRT, we look at what your initial symptoms are that you're reporting, and then we're going to gauge how you're doing based on how you respond with those symptoms. And as you start to see resolution of those symptoms and improvement of those symptoms. And so, that may help to teach us, what we need to tweak. If you're still noticing you're getting some improvement, but then some other symptoms really aren't improving, then we might need to change your dose a little bit. Like I mentioned earlier in the call, it's sometimes a little bit of trial and error that we have to, kind of tweak things and see how you do in response.
The inflammation very well may get better with turkey. So there are obviously a lot of reasons for inflammation, but the hormone transition is an important one. And I own a lot of patients similar to you that feel significant problems with inflammation. They start HRT and they feel much better. So I think there's a very good chance if this is the last hope for you, we get a good one, see a real difference with it. But don't waste your money on Dutch testing. Dutch testing, saliva testing, hair testing, blood testing, it's really useless. It's just a way to extract more money out of you. And it's not helpful. So, what's worse than no information is bad information. And these tests really don't give useful information. They give us bad information. And when you make decisions off bad information, you make bad decisions. So it's really not helpful. We're very expensive. And it's not going to guide your therapy. But I think, your first part of your question about inflammation, I think there's a very good chance this is going to help.
And our next question is from Rachel tonight. And she says, I'm 49 and I'm on my second month of HRT. She says, I haven't noticed many changes except I got my period 2 months in a row. And I was only getting it every 3 months. How do I know if the dosing is right for me? Or I got a period 2 months in a row and I was only getting every 3 months. How do I know if the dosing is right for me?
So just so you know what just happened, Dr. Kat is actually in the hospital, colon labor and delivery. So, she's not ordering pizza or get out. She's trying to save a life probably, so our crew excuse her. But that's a call behind her, which is why she's in her scripts. And I'm sitting in my wife's art studio this way. So it's a little different environment. I'm sorry. I got distracted now with all that. So give me the Reader's Digest left.
I'll read it again. It was a short one. But yes, and also for everyone watching, that is
she's 2 months in. She's in her period 2 months in a row, but she hasn't felt much benefit. So the fact that your period is more regular may or may not be from the HRT. As we said at the beginning, sometimes in the first couple of months it can trigger some bleeding or a period. Generally by the 3 month mark, bleeding, the periods tend to go back to whatever your baseline is, or just maybe coincidence. But either way, it doesn't sound dangerous, maybe a little, because you're enjoying not having free voices. Sorry about that. As far as the benefits go, usually we like to give it a good solid 10, 11, 12 weeks to see, because that's really by then when we should notice benefits. So you're getting a check-in. We call it the 10-week check-in. It's technically 11 weeks. It's actually kind of a funny story for that. When I designed this, I thought 10 weeks would be the right time. And after a while, I realized that was kind of a week too early. So we started doing it at 11 weeks, but the 10-week came kind of stuck. So anyway, at 11 weeks, you hit it, follow it. And if at that time you're still not feeling benefit, then that would be the time to increase your dose. And sometimes it takes a little bit of figuring out how your body is going to behave with the medicine. And sort of, we've said this a few times already, but my philosophy is I'd rather undertreat you and have to increase your dose a little bit to get you feeling better than to overdo it and cause you side effects and problems. So the idea is, I actually developed the algorithm that comes up with the initial dosing, and it's pretty good. Just purposely kind of undershoots just a little bit because I'd rather undershoot than overshoot. So it is possible that we may need to adjust your medicine. You'll be getting that follow-up, like I said, at about the 11-week mark. And that would be the time to adjust dose if necessary.
And our next question is from Brenda tonight. And Brenda says, I've read that HRT can possibly increase breast cancer risk. She says, both my mother and my grandmother, her mother, had breast cancer. Is HRT something that I could safely take?
So assuming you don't have a genetic marker for breast cancer, so most breast cancers are just random. And even when it's like your mother and grandmother, it's still more likely just a random thing than a familial thing. But if you have, say, a BRCA marker or a Lynch syndrome or one of these genetic markers for breast cancer, then HRT may not be the right thing for you. And in fact, it doesn't mean you can't use it, but it requires sort of more of an evaluation than we could do in this telehealth platform. And so we would recommend that you see an in-person doctor. But if there isn't a genetic marker, it's just sort of, your mom and your grandmother got breast cancer and nobody quite knows why, then it's safe for you to use HRT. And in fact, it's interesting. So the biggest studies that are sort of older studies showed that estrogen, HRT alone did not increase the risk of breast cancer. In fact, it slightly decreased it. Estrogen and progesterone together slightly increased the risk of breast cancer. However, when you looked at overall longevity, people that used HRT lived longer, healthier lives than people that did not. So, I always say the one thing I can say that nobody can argue with is that everybody has to die at least once. So pretty much everyone in the world would agree with that statement. And the question is, what's going to get you, right? Something eventually gets you. We don't want it to be breast cancer. We don't want it to be anything, really. When you're, old and at the end of your life, you want you to go to bed and, no suffering, and that's it. That's where I want to go anyway. But the idea is to put that off as long as possible. And HRT will help you do that, whatever ultimately ends up getting. Interestingly, though, these big studies were done on different types of estrogen or progesterone than what we use now. They were not the bioidentical forms of estrogen and progesterone that we use at Winona, and that's becoming more popular, at least around. And so the progesterone, the micronized progesterone that we use, there's been some studies, and they're not completely conclusive, but there are some studies coming out that it actually lowers the breast cancer risk rather than raises. So it seems from the information we have now, best information we have, that the types of estrogen and progesterone we use at Winona do not increase your breast cancer risk at all, and perhaps maybe even slightly decrease it. Again, I wouldn't say that that's conclusive, but that's the latest data, probably best data. There was just a big article that came out, a big review article looking at this, and that was their conclusion, was that using micronized progesterone and estradiol and basically bioidentical estrogen and progesterone, you really aren't seeing that same increased breast cancer risk they saw in these older studies. So all that being said, assuming you don't have a genetic marker for breast cancer, HRT should be safe.
And our next question tonight is from Sarah. And Sarah says, how different is HRT therapy for people that have had a hysterectomy but still have both ovaries?
So estrogen is really the key component to HRT. There are estrogen receptors. Oh, looks like the baby didn't come out.
Welcome back.
False alarm, no baby yet.
There's estrogen receptors in pretty much every tissue in the body. And estrogen makes a huge difference going through the menopause transition. The one thing estrogen does that we're not happy about is that it can overstimulate the inside lining of your uterus. And so adding progesterone fixes that problem. And so if you give someone who had a uterus just estrogen, they're going to have an increased risk of uterine cancer. But when you add progesterone to it, they actually have a lower risk of uterine cancer than if they were taking anything. So we add the progesterone to protect that lining of the uterus. Progesterone does give some benefit, but the main benefit, really, that's why we use it. So the big difference for someone that still has a uterus and someone that has a hysterectomy is whether they progesterone or not. So if you have had a hysterectomy, even if you still have your ovaries, you would use estrogen alone. If you still have your uterus, we use a combination of estrogen and progesterone. The fact that you still have your ovaries is a good thing, really, because it makes the transition a little more gentle. When somebody gets both their ovaries out, all of a sudden, overnight, boom, there's no hormone, and the shock to the body can be very significant. People can really suffer, and the amount of HRT we have to give goes way up to account for that. HRT really comes alongside the ovaries and helps replace what the ovaries aren't making anymore because they're becoming less and less efficient. And so as long as you still have your ovaries, we're still making some hormone. And so it's a lot easier to get the symptoms under control with HRT than if you've had both your ovaries removed at surgery. So those are sort of the big differences for women that have had no surgery, just had a uterus out, that had a uterus and ovary surgery. So progesterone, no progesterone, and really the dose of HRT that's kind of higher to get your symptoms under control.
And our next question is from Amy. Amy says, my mother and grandmother both had severe dementia before they died. She says neither of them took HRT, and I've heard that HRT can help stave off dementia. I'm sure my risk is still higher genetically, but is there research on people with a family history of dementia who take HRT versus those who do not?
I don't know if there's specific research on that, but this is something that's actively being studied by neuroscientists, and it's something that's, definitely we're looking at. There have been studies going either way, but now the newer research that's coming out is showing us that estrogen has a protective effect on our cognitive abilities and can help kind of delay and prevent the onset of dementia. So knowing that at a baseline, I would say you're probably better off on estrogen than not, given your family history. But I don't know if we have specific research, of your situation. But it's definitely something that I think could be beneficial to prevent your own risk of dementia moving forward.
And as a non-HRT bonus, this is a rapidly expanding field. It's amazing how.
Uh-oh. You froze for a minute. Back.
You really want to stay with your regular doctor, get your health maintenance, talk to them about this, because there are more and more drugs that are coming out and have started really early process can make a huge difference for you. So it's just great. So if you had that family history and you're not necessarily destined to have the same fate as those that came before you, because the advances in medicine are just going crazy in this field. So that's good news.
Right. Well, our next question is from Carolyn. And Carolyn says, I'm choosing this route in HRT because my traditional doctors say there's nothing wrong with me and I'm fine with no need for any treatment. But I have the early stages of symptoms, 30 pounds of weight gain, mood swings, hot flashes just started, and I don't like the way I've changed. One that I can't reconcile is the vaginal bleeding during intercourse randomly. Is this a known symptom? I don't have dryness or low libido, and I've had ultrasounds and tests.
So you can have changes from the genitourinary syndrome of menopause that can cause some bleeding with friction and with contact, but not really necessarily walk around feeling vaginal dryness or noticing that. It's possible to be having tissue trauma. But the important thing is, if you've not brought the bleeding with intercourse to the attention of a doctor who can actually do an exam and take a look inside, you absolutely need to, because there can be other things that could be causing that. So if that's something that's been happening, but maybe you haven't discussed it, I would definitely recommend an exam to evaluate for that because there can be some other things that we need to evaluate. And a good GYN exam with the speculum to take a look inside and look for other sources of the bleeding would be important before we just chalk it up to those urinary syndrome of menopause, or what we call GSM. There could be polyps on the cervix. There could be another abnormal finding. So it's definitely worth getting checked out.
And I would add a pap smear, even if,
Yes.
we're spacing pap smears out more and more. But this is an indication to get pap smear as well. So I would add that to the mix. But yeah, definitely don't ignore that. But it may be something HRT will.
And our next question is from Amy. Amy says, I started an estrogen progesterone cream early May. So I'm so glad I started HRT. Wish I could have started sooner. She says, I was having frequent short anxiety attacks on the regular, and they stopped almost immediately after starting treatment. She says, more recently, I've noticed that I'm less anxious in general and feeling more confident and calm overall. Love where this is going so far. She says, but I started having some hormonal acne appear on my chin this past month. I broke out really bad and wasn't expecting that during month 5. Will this likely settle down, or might it be an indicator for something else? Thank you.
I mean, if this is the first time you're seeing that, I would, just keep an eye on it for now. I wouldn't make any wholesale changes to your regimen if you're otherwise really feeling well. But that's something that, just keep an eye on. If you're noticing like the quality and the texture of your skin is changing, like say you notice your skin is more oily now compared to prior to HRT, it might mean that you need to change your face wash, and see what you're, cleansing with to see if you can reduce the bacterial load on your skin too, and that could reduce your risk of acne. If you're taking the DHEA, acne is one of the side effects of the DHEA, but usually we see it early on. But occasionally I see patients that have been on it for months and then all of a sudden start noticing acne breakouts. And usually this is a temporary phenomenon as your body's adjusting, so it should get better.
And our next question is from Christine. Christine says, I'm postmenopausal and I started HRT, bioidentical HRT, 3 weeks ago. So I've been on 200 milligrams of progesterone, estrogen weekly, patch, and vaginal tablets 2 times a week. She says 2 days ago, I started testosterone 1% cream. She says, I learned from another webinar that 200 milligrams of progesterone should only be taken for 12 days in a 28-day cycle. Furthermore, if I were to continue nightly, she said, furthermore, if I should continue nightly, I should be at 100 milligrams and not 200 milligrams. What are your thoughts on this?
So earlier, Dr. Green talked about the difference between continuous versus cyclic progesterone and HRT. This is an example of that. If someone gave you the instructions that you should only take it for 12 days out of the month, not really something that we usually recommend just because there's more of a risk of side effects from changing that. Also sounds like you're not on our medications because it sounds like a regimen that we don't typically prescribe. So definitely if you have concerns, if you have questions, I would reach out to the person who's prescribing for you. But yeah, we typically recommend taking your progesterone along with the estrogen throughout the month, not only for part of the month.
We prescribe 200 milligrams all the time. Depending on your dose of estrogen, 200 milligrams daily is a very reasonable dose. So wherever you read that, or very much that.
And our next question is from Anna. And Anna says, I jump out. Well, Dr. Green, I guess you will be taking this one. Anna says, I'm postmenopausal and I'm only here for low libido and hip pain. Can Winona help me, and how?
So there's a lot of reasons for hip pain. Menopause is one of them. And so if the hip pain is coming from the hormones, HRT should help that. And indeed, I see a lot of patients, hip and other joint pains do improve with HRT. So that's one way, is that it can help. It can also up libido. Libido is almost always multifactorial, and hormones is one of those factors. So as much as the libido is, poor libido is being driven from your hormones, HRT should help. But there are other reasons for libido, relationship issues, busyness of life, tiredness, other medications. So there are a lot of potential reasons, but it's a lot of times one of the reasons, so that usually the big portion of it is from hormones, and in that case, HRT can help you. In addition, HRT has benefits beyond the symptoms, so it decreases your risk of cardiovascular events, decreases your osteoporosis, decreases your risk of cancers. So you do get some other benefits as well besides just the hip pain and the libido. But honestly, if it's going to make your hip pain better and fix your libido, that's all you need.
I did want to come back and just really quick say goodnight to everyone and thank you for coming out. I do have to go deliver a baby now. They're getting ready. That was that loud ring. So hope everyone has a great night, and thanks for coming to the webinar, and I will see you on another webinar soon. Hopefully not on call the next time.
Good to see you, Treasure Cat. Thanks.
Right, have a good night, everyone.
Bye.
Well, that's good news. Before we started, she was worried that patient was not going to make it. So it looks like she's going to make it. So that's always nice to get one out agilely when you're not sure.
That is good. That is nice. And Carolyn, I see Carolyn says, "Woo, good luck." We'll definitely relay that, Carolyn, as well. And then we have our next question, Dr. Green. This one might take a little deciphering, so we'll see. I see Terrell is really wanting us to ask this question. I might need a little help from her as well, but we'll work through it. I'll kind of read it, and then if we get the right gist, we can kind of go from there. She says, recently I've asked my provider some questions about how my estrogen is being metabolized to my liver to make sure I wasn't estrogen dominant and having any problems. And I also asked about testing and told her how I thought it was really important to at least do a baseline because everybody's epigenetics, genetic makeup is different, and how we eliminate through our pathways. I talked to her a little bit about that, and she says, would just love to hear some of your thoughts on that. Yeah.
Let me share with that you're not estrogen dominant, so we'll just start there. It doesn't exist, and it absolutely doesn't exist in perimenopause patients. So nobody that's going through the menopause transition has a problem with having too much estrogen around. Quite the opposite. The problem is you don't have enough estrogen. It has nothing to do with the way it's metabolized in the liver. Everybody's liver works the same way and metabolizes estrogen. So that's a root point. This idea of estrogen dominance is not a real medical term. There is situations where the endometrial environment, the environment of the inner uterus, sees too much estrogen and overstimulate the estrogen. I sort of talked about that earlier, which is why we had progesterone. So some conditions such as PCOS can lead to an estrogenic environment in the lining of the uterus, which can lead to problems if not taken care of. But that's very different than this sort of idea of estrogen dominance that people throw out there. It really doesn't exist for anybody, but it absolutely doesn't exist in the menopause transmission. So, and I know you're not going to like that. Fortunately, it's kind of a bluntly thing, so I'm not sure if I can even help that. But that's just the truth. I'm a straight shooter, which is like completely transparent. So we don't have to worry about that. Our livers aren't really unique. I mean, we all have livers and all work basically the same way. And so we know how your estrogen is being metabolized. Tests for hormones are not helpful. I already tried to cover this. Hormones, the hormonal is very day to day, hour to hour, can change from all kinds of different things. And so if you take a hormone level, it may be completely normal at this moment in time, and you take it later in the day and it's completely abnormal. You take it again and it's completely abnormal, completely different way. So there's really no reason to do hormone tests. It doesn't give information that's useful or valid. And as I said earlier, the only thing worse than no information is bad information. And so when people do hormone tests and they get these numbers, they assume, oh, it's numbers, it must be real. But it's not numbers when measurements are wrong. Those numbers are meaningless. And so if you start making decisions based on these bad numbers, you get bad decisions. So there's no reason to do hormone testing. There's no reason to do baseline testing. There's no reason to do testing from time to time. It's just not helpful. The only reason to do testing is to line somebody's pocket, because testing, they're expensive, and tests make a lot of money for companies and for people that are doing the tests. We don't do that at Winona. We're trying to provide really high quality care that's standard of care, that's ACOG, the Menopause Society, stamp of approval. And both of those, both American College of Obstetric and Gynecology, ACOG, and Menopause Society, both say there's really no reason to do hormone testing in any form, whether that's blood tests, saliva tests, hair tests, touch urine tests, other kinds of urine tests. It's just not helpful. And so, I know there are naturopaths and other people out there that, want to do all kinds of testing, and they have all this, supposed research. But really, it's a great way to separate you from your money and make your wallet thinner. And that's just not right. So I feel very strongly about that. Somebody earlier said they went to the doctor, and their doctor told them there was something wrong with them, and they had all the symptoms of menopause transition. And this happens a lot. And it really, this is one thing that really aggravates me is someone goes into the doctor, they have all this stuff, and the doctor does a blood test, and blood test comes back normal, and they say, "Oh, is he hormones? Because your blood test is normal." No, that's not right. Fortunately, some of those people find us, and we get them on the appropriate HRT, and they feel better because, those blood tests weren't accurate. And so instead of getting the care they needed, they got dismissed, and that's UH. So I know I disagree with me. Yeah, that's okay. We agree to disagree. But I'm backing mine up from what the American College of Gynecology and the Menopause Society both say. And that's, we really work by using the best data and standard of care in the way we take care of patients, because that's the same.
Absolutely. Thank you so much, Dr. Green, for that in-depth answer. I think that was really helpful hearing your explanation of that on that end. We have one more question, and this is the last one for tonight. But this one is going to be from Stacy. And Stacy says, "Can you tell me why heart palpitations are common among menopause? And is there anything that can be done to reduce or eliminate them? Because I'm looking for some peace of mind."
So a lot of the symptoms of the menopause transition, including heart palpitations, really have to do with spikes of hormone, particularly estrogen. So what happens as you go through the menopause transition is that ovaries become less and less efficient at producing hormones. But they just don't kind of go away nicely. They do their best to keep making hormones, and so they start to spit hormones out intermittently rather than a nice, smooth transition. So it's not like everything's going well, and then they sort of gradually decrease. The hormones become spiky, and it's the spike of hormones that get a lot of the symptoms, traditional symptoms like hot flashes and night sweats, and some of the mood changes, anxiety. You had somebody earlier that said that their anxiety got better, and that's very common. It really has to do with this spiky nature of these hormones. I think that heart palpitations also have to do with that. And one of the ways that HRT helps with this is that it gives us a baseline amount of hormone. So when the ovaries spit out some extra hormone, it doesn't spike that level as much, because you've already got you're already pretty close to where you need to be. And so you don't get as much of a change. And you get these big waves and these spikes in hormones. And that's what helps improve things like hot flashes, night sweats, anxiety, mood changes, and heart palpitations for many people. Now, that being said, there are other non-hormonal causes of heart palpitations. And so you want to make sure that gets evaluated as well, especially if the HRT doesn't make it go away. You want to make sure there isn't something going on with your heart. So, but it's a very common symptom of menopause transition, and the hormone replacement therapy tends to do a good job when that's what's driving it.
Absolutely. Well, thank you so much, Dr. Green, and thank you so much, everyone who was able to come out tonight. We're so glad that you're here. We love getting to kind of have these conversations. And a reminder, if you have any other questions, or if there was a question you didn't get answered, Your Winona doctor is available 24/7 in your patient portal. So please reach out to them. It's essentially just like this, except you're doing it online. But that's a great way to reach out to them. They're there to help you. So please reach out there. And again, thank you so much for joining tonight, Dr. Green. Thank you so much. And I hope everyone has a great night.
Yeah, thanks for coming, everybody. Good night.
Good night, all.